as early as possible. So there is no age limit. Then if you're doing the conventional implantology or other things, then why are we here? To earn the quick money, to know about the science, or to give the minimum invasive treatment to your patients. So guys, I think you are here for all these things. Because in conventional implantology, what happens, you have to put the implant and wait for the 3 months. The patient pay you within the 3 months. But in basic implantology, you can earn money in the 3 days. Also, to know about the science, because there are different methods to give the teeth. But why basal implant? You have to know about that. And yes, there is no flap, there is no bone graft, there is no sinus. To give the minimum invasive technique for the patients. Okay. Then there are different methods. That is the conventional method. You have to take the flap, then put the parallelism, implant placement. Then after 3 months, you have to replace the teeth. By this method, you can also solve your problem. Again, there is a bone graft is there, surgical stent is there, and you can give the teeth. By conventional zygomas, you have to reflect the flap, and then you have to put the zygomas. And by this method also, you can convince your patient for the teeth. Okay, then the patient-specific implants are there. After mucormycosis, when there is a resection of the maxilla, mandible, this can in the highlight. You can also give the PSI implant, but they need the invasive procedures. But at last, patient got the teeth. Okay. Then vascular fibula graft for the cancer patient. You can also use fibula graft to give the teeth. Guys, these are my mentors, Dr. Stepanide, Dr. Vega, Dr. Antonete. Always choose a mentor wisely, because if your mentor is an open book, then you can proceed in your science. Now in basic implantology, how we treat the patients? There's a loss of teeth. Just I put the implant in the morning and evening, I completed this case with the aesthetic also. This is the another case in which I place the implant on the day 1 and day 2, I completed this case with the prosthesis and aesthetic also. This is the mandible anterior region, the sections case is there. I just extract the tooth on day 1 and put the implant. See, this is the wound on the day 1 and this is the healing on the 3rd day. And I give the prosthesis. Then this is the atrophic case. You can go with the PSI implants, zygomatic implants, all things. But in this case, I never reflected any flap, just palpate the bone and place the implants. And this I completed this case with the fixed prosthesis within 72 hours. And this is the follow-up X-rays. This is the case of ectodermal dysplasia. Guys who go through the CBCT, there is a height of 5.2 mm, 8.30 mm, width is like 4.12 mm, 2.25 mm. See the CBCT. You can see the CBCT here and see how much the bone is available. This case is rejected by all near about 49 to 50 dentists, and then he referred to me. I just palpate the bone. See, this is the case. Now, this is the actual scenario that the bone available. I just palpate the bone, whatever available, put the pterygoids, and I completed it case. See, this is the happy patient, and these are the 3-year follow-up also is there. This is the 3-year follow-up. Then we are doing the zygomas, but in the severely atrophic cases, and whenever the patient is not coming for the follow-up. Then I choose the zygoma. I never use the zygoma because zygoma is the rescue implant. It can be used at last whenever all the implant conditions are failed. I just put the implant flapless. This is the day 1 and at the day 2. And see the smile of the patient on the day 3. Then we can't place implant in the periodontally compromised patient like this one. We have to extract the tooth, wait for 3 to 6 months, then put the conventional implants, and then we have to replace the teeth. But I just completed this case in the 24 hours because I was a visiting consultant at the Ambezoga in Latur. I just extracted the tooth, see the condition of the patient. As Simpladent implants are smooth surface implant, see the X-ray, what is the periodontal condition. I just extracted and put my implants, and this is after 24 hours, and I just completed the case. And these are the follow-ups. Body heals itself. Somehow, in the past days, there is the images on the Facebook that the base implant was put the implant in the cranium and also, but we take the positively. This is my mentor, Dr. Weber. He's the only glabella man on the earth who put the glabella implant to avoid the flexibility and give the proper trepidation. There is no need of admissions, just is on the dental chair. See there is no maxilla, there is no entry bone support. So we plan for the zygomas and the glabellas. And I just put this framework and completed this case. This is the post-operative CBCT scan. So, guys, we have the answer. What's Tiffany, sir? For me, implantology starts where others gave up. Basal implantology also offers a unique opportunity for the implantologist to treat the case which cannot be treated with the conventional implant system. How we achieve this functional loading with high insertion torque, engaging the basal bone, rigid splinting, avoiding the offset forces, and no cantilever. We'll go through these points. Now, what is the definition of the corticobasal implantology? A single piece fixature being smooth surface and having minimal permucosal emergence, essentially engaging the corticobasal bone and buttresses and distributing the occlusal load through apically engaged threads, being splinted within the 72 hours and thus follow the immediate functional loading protocol. Now, we'll go through the definition. A single piece fixature means in conventional implantology, there is a implant is there and there is abutment is there. The abutment and implant are fixed with the screw. So there is always a micro movement at the screw. So sometimes the screw get fractured, implant get fractured, or screw get loosened. But in this implantology, it is a single piece. So it never get loosened with the abutment. Again, it is a smooth surface. So there is no chance of infection with this. You can use in the diabetic patient, infected in the cardiac patients, in osteoporotic patient, in the smoker also. And sometimes there is a peri-implantitis or sometimes there is a periapical infection with the implant. In that case, just we have to adjust the occlusion or just open the flap and curate it, and again that implant will be okay with. Also, we are putting the implant through the sinus. Sinus don't want the rough surface. So these are the highly recommended implants for the sinus also. Then minimal permucosal emergence. As we know, as we are young, the blood supply is the centrifugal from midline to the periphery. But as the age increases, the blood supply is the centripetal from the periphery to the midline. So whenever you raise the flap, there is always the bone loss. So to avoid that bone loss, we never raise the flap. Again, there is a minimum trauma to the patients. So do you know the platform system in which the abutment is smaller than the implant cervicalism? So there is a good emergence. But in our case, there is the 2 mm body is there. So there is always a good profile emergence. Also, you know which is the best bone graft? Do you know? our bone is the only best bone graft for us, because other bone graft acts as a scaffold. So whenever in extraction socket, by taking consideration of jumping distance or all the things, you just put the implants accordingly. In conventional implant, whenever there is no bone, then we have to create bone first and then you have to place the implant. But in the basal implantology or corticobasal implantology, you have to just take the implant design according to available bone. Then engage in the corticobasal bone or buttresses and distributing the occlusal loads through the apically engaging threads. Guys, cortical bone and the cancellous bone. Cancellous bone, whichever we used in the conventional implantology, it is like that it have the more blood supply. So there is more chance of the infections. There is more remodeling is there. But for implantology, we need less remodeling. So we use the cortical bone. That is more dense, there is less blood supply and less chance of the infection. See, these are the trabecular bone or cancellous bone, and this is the cortical. There is highly dense bone is there. So we need the less remodeling. It is heavily corticated and its load bearing capacity is very high. See in this X-ray, the conventional implant, there is a peri-implant that is around the implant in the alveolar bone, but it is engaged in the cortical bone and it is attached with the anterior tooth. It is a successful implant after 12 years also. These are some buttresses. There are vertical buttresses, transverse buttresses, which are used to engage the cortical bone. We can use the nasal floor. We can use the pterygoid. We can use the lingual cortical plate, buccal cortical plate. All these are the buttresses and cortices. Now, what happened in the conventional implantology? See, in the traumatic patients, when we put the plates, first of all the forces are taken by the plates. After healing, if there is a bone loss is around the plate. Why? Because bone go in the low state of mineralization. Because if the plate is there, all forces are taken by the plate, then bone get resolved. So we have to remove it after the 6 months. Same thing happened with the conventional implant. It is a conical in shape. So it is larger in at the cervical region. So all the forces are taken by the implant at the cervical region. So there is the marginal bone loss in the conventional implant. Then it gets super infected with the microorganism. This is the article is published where it is proven that is why marginal bone loss is there. First, there is the marginal bone loss with the low stress effect, and then there is the periapical infection. Yeah. Then, see, what is the osseointegration? We guys never tell this definition to our patient. We said if you get it fitted with the bone, then it called as osseointegration. How will you identify osseointegration on the X-ray? So many of things told dentist that there is a white line around the implant. Guys, do you know there are two types of bone loss in the cancer and in the cyst? In cyst, there is a bone loss is there as like a there is a white line around the cyst, but in the punch out, like in cancer, there is no bone line. Cyst is as like a foreign body. Body don't want the cyst, so body get encapsulated that cyst. That's why that white line is happening. Same reason, body don't want any implant or any foreign body. Implant is a foreign body. So body encapsulated that implant. That is the white line. So in basal implantology, we just fix the cortex and osseointegration is the biological answer of the osteofixation. This is the article which is published by Professor Donor in the laboratory. Then there is something is more interesting. Your implant must be 1.5 mm from your tooth. There is a 3 mm distance between your two implants. That is 1.5 mm each. Same thing applies for the bone. Whenever we are putting the implant, there are the micro cracks. So they travel for 1.5 mm. To get the better condensation and compression, the pitch of implant should be 1.5 mm. That's the beauty of this implant. Implant, they scientifically proven that they are giving the 1.5 mm of pitch. Then, why we are sprinted within 72 hours and how will functional loading is there? Guys, you know, in orthopedic science, whenever there is a fracture of femur or anything, then the guys operated the patient and asked patient to walk on the next day. Why? Because whenever there is a function is there is a bone formation is there. Because if the bone don't have any work, they it get in the disease atrophy, like the Wolff's law. And whenever there is injury is there to the bone, so to form the precursor to the osteoclast, and osteoclast starting the digging. So from starting of the precursor cell to the osteoclast, it takes the 72 hours. That's why we immediately load within the 72 hours. That is the disease atrophy. That is the Wolff's law. Why? Activation phase is there, resorption phase is there. So that's why we immediately load in the 72 hours. Dr. Ide Dentals is the parent company. They distribute this implant. These are manufactured in the Switzerland since last 30 years. Then there are different types of implantology. Delayed implantology means extract the tooth, wait for 3 months, and then put the implant and wait for 3 months and give the. Immediately remove the implant and place the implant and then delayed functioning. Then immediate functional loading, that is corticobasal implantology. You have to functionally loading within the 72 hours. There is immediate loading versus immediate functional loading is also there. Immediate loading means you have to just use the teeth in the anterior region where there is no functional. But in the posterior region, we need the immediate functional loading. But the drawback of the conventional implantology, we need the much more large amount of bone. It requires the healing time for many months, often requires the additional bone augmentation surgeries. Difficult to use the posterior region when we are using the conventional. This is several pieces, so multiple parts are there, they fixed with the screws, and so that the cost is increased. What is the strategic or basal implant? It is not like this type of screw is like a basal implant. No, any implant which is placed in the strategic or basal bone, that is called as the strategic implants. And guys, there are different types of implants. There are multi-unit implants, there are KOC implant, there are BCS EX implant, there are BCS implant, there is a situ implant. You have to choose the implant according to the bone availability. Then advantage, that already told that it is a flapless techniques, simple technique. In maxilla, you can complete the case with a single drill also, and it is cost effective and immediately loading. And highly atrophic cases, we have the answers when other give up. These are the disc implants which are used earlier, but now it is not used. Now we are using the BCS implant, and it is compatible with our bone also. These are bendable implants. You can bend up to 180 degree also. So to get the prosthetic here, and see advantage of this smooth surface. See another case here. The periodontitis case is there. I just extracted, curated well thoroughly, put the implant, the X-ray, then the metal trine zig is there. This is the prosthesis. It is immediately after on the third day, and this is the follow. This is the follow, 1.5 year follow. Now it is get completed 4 year also. Now, what is the use of smooth staples? This case is operated in 2020. patient paid me some amount and he will ask me, I will come after in follow up, I will give. But she never came. She came in the last year and there is a bone loss in the anterior region. She is the bone loss is there. And this is the intraoral condition. I just expose that flap, curate it thoroughly, and see the healing. Just appreciate this healing. As it is a smooth surface, it never gets failed. See the healing. These are the different types of implants. Now, this is the case. Actually, in the strategy implantology, two things are very important. One, treat case as a whole because the load distribution must be equal. Okay. So, in this case, and second one is the you need to follow. If your patient giving you follow for at least next 6 months, then and then only operate that case. If it is not possible by the patient, then just reject that case because it will get fail. In this case, it is a full mouth case, but as a consultant, the dentist told me that do only the anterior region. So I done the multi-unit in this case. So I will join in the if he need the full mouth, then I can join this multi-unit with that implant also. Guys, this is the Simpladent website. You have all the data like the articles, all theory parts, videos are available on this website. You can go through all the articles. If you want any data, previous data, then you can go for the on this website. Why in basic implantology we use the multiple implants? According to Cope's analysis, we should need minimum 8 implants in the maxilla and 6 implants in the mandible. So we put the more implants. And see, we are engaging at the cortex only. It is a 3.6 mm and it is a 2 mm body. So the only bone to implant contact is at the cortex level. So we put the more implant. This is the also a consultant case. Patient operated for the conventional implant. The implant get loose after the 3 months. He guys then wait again for the 6 months, but there is no improvement. So in this case, I just removed all the implant upper side, just put the basal implant, and I completed this case within the 3 days. This is also another case where I completed within 3 days. These are some cases. See the periodontal condition. It is a 6-year-old case. This is the another case as periodontal condition. As a smooth surface, I can do anything. This is the 2-year follow. This is the follow. Then some guys ask about there is no retractability in the basal implant. First of all, guys, if you are using the single piece implant, then the retractability option is no there. But why we need retractability? If there you have perfectly placed the implant, you have get perfectly manage the soft tissue and put the prosthesis, there is no need of it. And if there is a mobile, then you can just pull the denture and just cut implant. You can easily retract. Again, if you want to change the prosthesis, then you can go with the multi-unit implants. These are the VCS multi-unit. It is already 15-degree angulated. This is the hex drive, the insertion tools. Only 2 to 3 instrument extra needed. This is the insertion tools is there. Previously, there was the impression coping was there, so I don't use. But before 5 years, just they give the scan bodies. So I started my practice with the multi-unit because impression taking is the most difficult task in the multi-unit. Now we have just scan, send to laboratory, and it will come on the next day. And the beauty of this implanted multi-unit, it is a smooth surface. And the advantage for multi-unit is the only the retrievability for changing the prosthesis, not for the implant failure. This is my first case. I just place the implant. See, the implant level is at the tissue level, not at the bone level. So there is no peri-implantitis. I just put the scan bodies and this is the processes. Principles are the same for the BCS single unit and the multi-unit. There is no change in the principle. We have to just engage the cortex and complete the case. This is another case in which I place implant. See the healing, and you can retry after 7 days and remove the suture also. This is the case. Beautifully clear. See the healing. This is the follows. See the bone formation here. This is also case with the multi-unit. Extracted the tooth, put the implant, bone bed is formed because there is a gummy smile is there. Just put the implant, process it, soft tissue, scanning is there. See the healing. That is the ginger formula, like I used that scan bodies. See the healing on the 3rd day. Then the metal train. This is the final processes. There are different types of materials are there. Hybrid material is there, graphene material is there, ceramic material is there. I will always prefer either hybrid or graphene. I never prefer for the ceramic because if there is pinpoint is there, all the trauma goes to the bone. But in the hybrid, it will wear off. The teeth itself wear off. As we know, when we are young, there is a cusp are very sharp. As we are getting age, they get flat because tooth is will itself get the flat, but they never gives any injury to our bone also. This is the case I completed. These are the follow-ups. See the healing. If you don't want to struggle with the soft tissue diet like suturing and then remove after 7 days, just do the extraction, wait for 6 weeks, and then you can put the implant. This is the case where I just extracted, then I will go for the implants. In this case, the scanning may be also good because there is no blood. If there is blood in the field, then there may be some difficulty in the scanning. See, this metal train, it hardly take the 15 minutes, and these are the final processes. The main purpose of the retrievability or multi-unit in my thing is the if you want to change the material in the future. This is the case. Lower I just put the multi-unit and give the ceramic processes. In the posterior region, I use this ratchet to fit the, because in posterior region it is very difficult to place the screw. This is the case. This is the another case where I extracted it. I put the multi-unit and see the healing on the day. I also done socket shield in this technique. See the healing. This is the trial JR I have taken to final processes, and this is the trial, and this is the final processes. I use graphene in this case, so I can rely in here. In this region, I can rely after 7 days, 15 days every time, and there no need to remove this prosthesis. You can reline in oral cavity also with the graphene. This is the first case I was asked about. I just extracted and placed the single piece implant. It is a case near about 7-year-old. That time I don't use multi-unit. But in this case, if you use the multi-unit and in future you want to replace that teeth, then you can easily attach with the multi-unit. For this case, multi-unit is a very useful. See, this is the case where I plan for zygoma in the upper. When you are planning the zygoma, so you have to go for the single piece only, because multi-unit is not available in the single zygoma. See, this is the case. Extraction, implant placement, scanning. In upper, I place the single piece, and lower, I use the multi-unit. This is the trying. This is again the graphene, and see the result. This is another case where I use the zygoma in the maxilla without flapless. Single piece in upper and lower, the multi-unit is there. The jaw relation. Jaw relation is very important in the thing. The trying, and I just completed this case. These are the follow-ups. See the healing. What do you think? In this case, zygoma is needed or not? I just completed this case without the zygoma. I put the triple pterygoid here and multi-unit in upper and lower. Sometimes there is bleeding is there. We have to reduce it for the lip line. We have to reduce maxillary bone. And there was a bleeding was there. So we can't do scanning at that time. You have to just place the implant, take an impression, pour it, and scan it on table. And you can go with the multi-unit in bleeding case also. So I use multi-unit in this case in upper, and in lower, I completed the single piece. Again, after post-mucormycosis, there is a maxillary resection was there, and another implant required another surgery or another admission. Patient don't want to get admitted. Just without flap, we completed this case. See, there is no flap is there. Here there is a impacted edge was there, so I just take the flap. But here in this region, there is no need of any flap. And see the bar, and over this is heat cure acrylic prosthesis was given, like this one. This is the heat cure. So patient can easily remove, because there is a hole in the maxillary sinus. So we don't want to get infected again. Then why we give the sanitary pontics in the multi-unit or in the single piece? We always give the modified ridge in the maxillary anterior region, and in posterior region we use the sanitary pontics, because whenever you are using the multi-unit, there is always a rule: after every 6 months we have to remove that prosthesis, wait for 1 to 2 days to heal, and then again we have to put the prosthesis. But no one can do that. So we need the sanitary pontics. If patient doesn't come, or if you don't have come, we have to do the modified ridge in anterior region and sanitary pontics in the posterior region. See, if you don't remove that multi-unit after every 6 months, what happens to the ridge? So we have to remove it. Now you can complete it. You can use the basal implant in the aesthetic region also. You can use the zirconia crown also. Just put the 2 implants and see the results. See another case. Here, you can't judge which teeth is replaced. Let's see. This is the tooth which we replaced. This is the tooth broken by accidentally. It is intruded. Just remove it. Place the implant. See the zenith is there. See this one. There is it. Just engage in the cortical bone. And by bending, we achieve anti-rotational property also. Is the follows. Also, in the anterior region, by engaging the cortex, we can give this zirconia also. This is the another case in which the maxillary there is a bone loss is there. So conventional implant is not possible. See the CBCT scan. The results are like this: width 3 mm, height 8 mm, height 5.8 mm. But I put the implant of 17 mm, 20 mm because maxillary bone is not a straight. Radiologist give us the wrong diagnosis about the bone. There is always bone is there in the maxillary anterior region. Let's just put the implants and see the results. This is another case operated by the Dr. Viego with the nasopharyngeal carcinoma. There is a nasal bone loss is also there and soft tissue loss is also there. They put the glabella, give the prosthesis. Now they also give the soft tissue prosthesis here. They prepared the nose and give this prosthesis. There are also the KOC, that is king of compression. Whenever there is a bone is available, you can use this rough surface also. But the beauty is there is the smooth surface at the cervical region. There are micro grooves are there. You can replace single tooth. For molar, you have to put the two implants and they splint it together. See, this is the quadrant also. We can replace. How we replacing? You can use complete KOC case. It is completed with the. There are SCT implants is also there. These are like the root form conventional implant, but these are the laser treated. See, there is no flap. Just put the implant, X-ray, impression, process on the third day. Now, many times all the guys say that the complications are there. Yes, there may be the complication, the immediate complication that there may be bleeding. Like in the extraction socket, there is a bleeding. What we do, there is a pressure package there. Post-operative, there may be pain. We can manage with the painkillers, and we need follow-up because if you are not giving any follow-up by the patient, then there will be chance of the failure. So to avoid this type of delayed failure or post-op failure, you need the follow-up. So what is my conclusion? Patient selection and counseling is very much important. Selection of implant type is also important. Follow-up is important. And in extraction socket and heat socket, you can use the socket shield technique, or you have to put the implant like zygomas. And obviously, by this is the cost effective also. So choose the design according to the bone scenario. Guys, we are as a Simplantin team, we are taking the 4-day course in which 4 or 5 teachers are coming and they tell about anatomy, how to place the implant, how to handle the complications, and how to achieve the good aesthetics with the good follow-ups. And this is the 4-day course in which mentors are coming. This one is the in-house shadow program was there, and there was a PG diploma is also available in the CORTICOBASAL implantology by the Simplantin, in which you you operate on the 4 jars, that is the 2 full mouth implants, 30 to 40 implant you are placed during this curriculum by yourself, and there are many international and national faculty are coming to teach you. Also, this is the 8 to 9 months program, but we distributed within the 5 modules. The implants. And of course, as I'm going through all these stages, right now I am the official I am teacher of the implanting. Thank you guys. Again, I want to share something about the Simpladent. It is the parent company, that is the Ide Dental, and in India, the distribution is by the Simpladent India. And it is totally made in the Switzerland since more than 30 years. And we are using the metallurgy like TI6. So it is the fracture resistant. And right pitch is our the most beautiful design. And the long arm is there. So there is a bendability. And blunt teeth is. The tip is blunt. So there is no injury to the any soft tissue. And it is there is the manufacturing registration number and CED. Yes, your Indian license is there. So in Indian court, it is acceptable that this implant is stand. Many times some implant companies come to you. What happened with that? That design is not good. So there may be maximum 5,000 to 10,000 implants. Yeah, but we can optimize the quality. And there is the no, the curriculum. The Jaipur diploma was there. And the participant of that. We are conducting the courses all across the India. Just we have to just contact me or by Simpladent website, you will get the results. And of course, our course have some fees because we don't give the cheap knowledge. So we have some. Thank you guys. Thank you everyone. You can now ask question on WhatsApp also or in this chat also.
Thank you, Doctor. Thank you for this presentation. As we are moving towards the end of the session, we'll have a question answer part where the participants could ask the questions regarding the topic in the chat box. Doctor, there is one question put forward by one of the participant named Juvin. He have asked, post-OP pain after 2 weeks, what could be the possible reason?
There are 2 to 3 possible reasons. Number one, bone is in the revolving phase. Okay, the osteoporotic activity get faster. That's why there may be pain. So you can give the pain killer. Second, if there is these are the isoelastic implants. They are isoelastic implant. So there may be change in the occlusion. So patient is chewing from the one side or only from one side. Then there may be the chance of the pain after 2 weeks also. So the maximum chance of failure is within the 6 weeks. After 6 weeks, it will never get fail.
Thank you, Doctor. The question is that can corticobasal be done guided after fabricating a CD for accurate prosthetic rehab?
Yes, you can take the guide of the CD also. But what happen when you are printing like the fabricating the guide in hidden children's jaw? If there is a 1 mm changes at the level of the alveolar bone, there are 5 to 6 mm change at the cortical level. So we have to just take the use of your finger as a CBCT and you have to put the implant. But of course, for the prosthetic purpose, you have to prepare the CD first for the good prosthetic rehabilitation.
Thank you, doctor. Is immediate functional loading best for basal implants?
Yes, the protocol is the same. I already told. If bone don't have any function, then it gets in the disease atrophy. So we need the functional loading in the basal implant. Bone always need work. You guys already know when we are giving the dentures, there is always a bone loss is there. If there is a tooth loss is there, there is always the bone loss is there. Whenever there is a tooth is there is no bone loss is there. So we have to give the functional loading in the basal implants. Next question. How much we should charge for a full mouth PFM case? Yeah, this is a good question. You can use different strategy. See, if your colleague or dentist nearby you is charging full mouth case 4 lakh, you can charge 4.5 lakhs because you are giving the immediate loading. Okay. Same thing with the quadrant also. If you are putting the replacing the quadrant, and if you're the conventional guy is putting the 3 implants for the 35,000, like 1 lakh 5,000, you can ask for the 1 lakh 20,000. So it will be comparable. It will be not just much more or any high cost. So you have to do the accordingly. Jaipur course fees, please pin me on my WhatsApp number. I will give you all details. If we replace from the canine to first molar, can we want
First molar, can we?
if we replace from canine to first molar, what all we want to consider? Yeah, in which there is it is a quadrant, and here maybe the canine guided occlusion was there. It must be needed, and you have to engage the cortex and the nasal floor and the floor of the sinus. And if there is second molar is available, in my consideration, you can use that second molar also. And if there is no first molar and no third molar, then you use the pterygoid and anterior nasal and use the process. No intraoral welding concept in the implanted. What other anti-rotational methods? See, whenever you are putting the implant, to give the prosthesis, there is a framework is there. Your framework itself acts as a welder. So there is no need of intraoral welding. By giving the intraoral welding, you are giving the wrong prosthesis because your prosthesis can't fit on the abutment at the neck of the abutment. So it will get infected. So give the good prosthesis you need at the cervical region of abutment. So there is no need of intraoral welding. And anti-rotational methods, there is the bending is there, and your framework itself acts as anti-rotational. In the end maxillary anterior region, if you want to replace the tooth, you can give the palatal wing for the 6 months. After 6 months, you can remove that palatal wing. Post-op medicines after basal implants. Same things, whichever medicine we use in the extraction after extraction. How to maintain occlusal stability in the corticobasal implant also. Just give the follow. There must not be the pinpoint. Upper Bull's law is the there. Upper lingual fossa in the lower. There is no canine to canine contact. And always do follow for 1 month, 3 months, 6 months, 6 months. How can we take care of nerves while placing the basal implant, particularly in the matter? Yes, sir. There is some landmarks are there where nerve is not coming in our way. And actually, we are not bypassing the nerve. We are just engaging the myeloid region. Nerve is far away from the our site of insertion. Splinting tooth and implant is allowed in corticobasal. Yes, it can be possible, but the tooth should be vital, because if it is a carious one or acidity, after some days, what happen? The tooth will get collapse, and you have to remove all the implants. If implant fails, how to remove? If it is mobile, just pull the prosthesis, cut, place new implant, and complete the case at the same time. What about the recession after 2 to 3 months of implant placement? Sir, our soft tissue follows the hard tissue. So we have to prepare our hard tissue as like there is no recession. If there is no recession with the hard tissue, then there is no recession with the soft tissue. So we are good. If we place the implant 1.5 mm from the adjacent tooth, can it get changed angulated? If we place the implant 1.5 mm from adjacent tooth, can it change angulation of adjacent? No. Why? No, it will not change. If we have a compressed necrosis, what? If we have a compressed necrosis, what can we do? Just remove the implant. If your question is like that, there is a compression necrosis there, then just remove the implant. Just wait for the 6 month and then place implant. Sir, if there is a bone loss is there now. So after removing or after curating it, there is a blood clot is there that will automatically convert it into the bone after the 6 months. Then you can put the implant. Dr. Shivam Sharma. Sir, I take minimum 5 to 6 years to make this PPT, sir. How can I show you?
Excellent presentation, Dr. Lakshman, as always. All the best.
Thank you, sir. Can I end? Yes, already told, sir, interval welding, how it failed. Yes, Dr. Shivam Sharma, please contact me. I will share some data with you. Can we conclude the meeting?
Yes, sir. Yes. Thank you so much, sir, for sharing your knowledge and expertise. Surely, many of us would leave the discussion with amazing takeaway points and implement techniques as per discussed. Once again, thank you so much, sir. It was a wonderful and informative session, and we really appreciate your valuable time given to us for this series episode.
Thank you, IDP also.
Thank you, sir.
Okay.